Hello, this is Dr. Patrick Hu, CEO of Moffitt Cancer Center, and we're here at the ASCO annual meeting 2023. I have the privilege of being here with Dr. Danielle DePalo. Thanks a lot for being here with us today.
Thanks for having me.
She's a surgical research fellow at Moffitt Cancer Center, and she has done a really exciting work here with looking at patients who have melanoma that has gone to call it an in-transit disease. Tell me, what is melanoma and what is in-transit disease?
So melanoma in transit metastases are sites of melanoma that pop up in the lymphatic system. So if you had a primary melanoma, say on your hand, in the lymphatic system on the way to the regional nodal basin, you can develop sites of in-transit disease called in-transit metastases. So the treatment for these, there are a few different options, and we don't really know which one to use in the first line setting. So for this study, we looked at patients that received intratumoral injections called IT, isolated limb infusion and isolated limb perfusion, which is installation of cytotoxic chemotherapy, and patients that received immune checkpoint inhibitors. We looked at this in patients that were treated at 12 institutions, and those pictures up there, and over the span of about 30 years, and we did this in a retrospective fashion.
So you can get these in-transit lesions on the arms, also on the legs, right?
Yep, you can get them anywhere on your body, anywhere spreading from the primary site to the regional nodal basin. It is more common on the limbs and especially on the lower extremities.
And once you get them, it's pretty serious, right, when it's starting to spread that way?
Yes, so in-transit disease is considered part of the N in the TNM classification, and it is considered stage 3 disease to have in-transit metastases. That can be with or without regional nodal involvement as well. But it is not considered distant metastatic disease, it's a regional disease.
Wonderful. All right, so there's a number of ways to treat, and the question is, what's the best approach? To give drugs that stimulate the body throughout the system, the immune checkpoint blockade, to directly inject the lesions, or to isolate the vasculature of the limb and perfuse with a chemotherapy called melphalan, right? That's pretty much what you looked at, right?
Exactly.
All right, so what was better?
So when we looked at it, we saw that toxicity was pretty much as we would expect it to be. Checkpoint inhibitors have a higher rate of requiring pharmacological therapy and hospitalization for management, whereas limb infusions has a higher rate of lymphedema. So no surprises there. When we looked at response rates, the local regional therapies, so the intratumoral therapies and the limb perfusion therapies had higher overall response rates. But when we looked at the progression-free survival, the melanoma-specific survival, and the overall survival, we saw that intratumoral injections and the systemic checkpoint inhibitors had better outcomes compared to the limb infusion and perfusion. And that remained true on a multivariable analysis. And I think in part this is related to the fact that the limb infusions and perfusions have been done a lot longer than the intratumoral therapies and the systemic therapies. So when people progressed on limb infusions and perfusions 20 years ago, we didn't have the same options for them that we have now.
I see, so it could have been really a time-based issue.
Exactly.
So you almost have to go back and do the analysis in the last decade.
And that is exactly
and
our
just
plan.
Look at that,
Yep, so we're going to look well within the last decade.
Yeah.
It's about half of the patients in this study that have actually been treated in the last decade, and we're going to see if this still holds.
Because if someone progresses and gets a melphalan perfusion, you're going to put them on immune checkpoint blockade if they progress, but we didn't have that 20 years ago.
Exactly.
Okay.
And I think another next step would also be looking at sequential therapies, combination therapies, that sort of thing, because these were only as monotherapies. Certainly it's interesting to consider combining a couple of these regimens.
That's great. Well, Danielle, some people have hypothesized that the intratumoral therapy, it's a virus that they give intratumorally, right? Herpes virus, called TVEC, or the perfusion that causes a lot of tumor to break up, is actually going to be stimulatory to the immune system, almost like a vaccine. Did you get any insights into that as to whether or not some of these treatments were causing a systemic immune response? Do you think any of your results give you a little insight into that?
So I think potentially we could argue that we are seeing a little bit of that effect in our distant metastatic free survival. You can see that the intratumoral therapies and the limb infusion and perfusion actually had longer distant metastatic free survival. So that is out of the area that was treated. So you could argue that there are, potentially systemic effects contributing to that.
Yeah, because you might imagine that in the future we're going to want to do both, right?
Yeah, exactly.
It's not one or the other,
yes.
but we're going to want to inject immunologically stimulatory substances into the tumor, as well as give immune checkpoint blockade, right?
Yeah, certainly a possibility, and
Wonderful. Okay, anything else with your findings?
Obviously there are some limitations to this project. We already kind of talked about them, which is that it wasn't randomized. Obviously in the ideal world we would have conducted this in a randomized fashion. I think that's unfortunately easier said than done with, local, regional versus systemic therapies, but that would really help us answer our questions. And I think also, looking in a contemporary cohort to help, address the discrepancy in treatment availability. And then, like I had mentioned, looking at next line therapy, so what people go on to next, and looking potentially at combination therapy to see if that modulates outcomes.
Patient coming in clinic tomorrow. Mm-hmm. You're in clinic, you see them, they have in-transit lesions. What are you giving them?
So I don't think this is going to change what we're offering at this point in time. In general, it's kind of a multidisciplinary discussion based on the patient, their sites of disease, their comfort with the different regimens, and what comorbidities they have. Certainly if they have, autoimmune disorders, they might not be the best candidate for checkpoint inhibitors. If they have really bad lymphedema, they might not be the best candidate for a limb infusion or a perfusion. So, at this point, it's still very much a patient-specific decision. Also, people might not want to come in every 3 weeks for an injection or for systemic therapy. Limb infusions are often one and done. So, if they live thousands of miles away from here, that might be the best option for that. So I think at this point, we still should make patient-specific decisions.
Great. Well, thanks so much for your time today.
Yeah, of course.
Dr. Danielle DePalo, Research Fellow here at Moffitt Cancer Center.
Thank you so much.